as components of a successful practice, a team-based approach. Our objectives are to describe the importance of using a team-based approach, name the team members recommended for an office-based buprenorphine program, describe the roles and responsibilities of each team member, address how your administration can support building a team, and recognize how the information provided may assist you in your clinical settings. And I do want to say, I think this is one of those subjects where you might look at it and think that it's not going to be the most charismatic, but I think it's a really, really important one, no matter what your role on the team is, to understand the big picture of what we can do to take the best care of our patients. And also, this is what ECHO is all about, is leveraging that local capacity to make sure that we can take care of as many people to the best possible standard. So this really is focusing on that team aspect of leveraging resources. And I do want to make a note here because integrated treatment is something that I think most people strive for as healthcare providers. And in this case, it really is proven out by research that it is the best model of treatment for people with serious mental illnesses and co-occurring substance use disorders. SAMHSA considers it the gold standard approach, as well as really all the other major regulating and research bodies. It does allow clients to receive combined treatment for mental illness, substance use, and psychosocial needs from one treatment team. And I want to point out here, if you have for yourself or maybe for a loved one ever had to struggle through the vagaries of navigating the healthcare system with a team that is not well integrated, you know how frustrating and demoralizing that can be. And that's particularly true for patients who are struggling with mental illness and substance use, and very often also have those psychosocial needs. So you can see how for this population, it would be nice for everybody. I hope it for all patients, but it is particularly crucial for patients in this population to have a well-integrated treatment team who communicates with each other and who are all on the same page about treatment and recovery. To that point, there is a difference actually between multidisciplinary and interdisciplinary. A lot of people use those terms interchangeably. But really what we're aiming for is interdisciplinary, meaning that we're really woven together. It's not just that all these different disciplines are kind of housed in the same place or co-located. It's really that we're working together in a truly collaborative manner and that we understand one another's roles and how we can work to synthesize our strengths, so to speak. So let's move to what recovery looks like. These are some of the main concepts for the treatment team, or the sort of bedrock principles. And a really important point in substance use disorders is that recovery is more than just symptom remission or stabilization. That's obviously a really critical part. But recovery is really a ground-up paradigmatic process for patients. It involves the development of a totally new sense of meaning and purpose for most people in their lives. In fact, for SAMHSA, they define recovery with the sort of core concept of hope for the future. And I think that says a lot about how kind of all-encompassing recovery actually is, and how much work it takes for the patient and the team to get them there. So another one of the main principles is including all of the people who work with the patient, as well as the patients themselves in the planning process. You don't want anybody to be, going off on their own in terms of the treatment plan. And critically, and this is the next point, you really want to make sure that the patient is the centerpiece of the treatment plan. This both means making proactive efforts to ensure that the patient understands what the options are available to them and are giving, honest feedback. And it also means making sure that they feel comfortable to give that, because some patients are very eager to please and they'll just kind of go along with what you suggest. But what we do know on the behavioral health side is that the more the patient feels in charge of the plan and feels that it reflects their own goals and what approaches are going to work best for them, the more likely they are by far to stick to it. So it's best for everybody when we're able to get everybody on the same page with the patient at the center of the treatment plan. An infrastructure does need to be in place to promote team cohesion and allow the team to focus on clinical work. So we'll have a piece at the end of this presentation that's exhorting any of you current or future administrators to make room for that, because that is a really important part of making sure everybody can show up and do their best. So it's not just what we do individually, but what sort of systemic resources are in place for us to be able to collaborate effectively. And then the expectation that as teams, we're using the treatment plan as the fundamental underpinning for all clinical encounters and interventions. And the reality is that just the way that healthcare systems works, Sometimes we come up with a great treatment plan at the beginning, and then it kind of just starts to migrate to the margins, as treatment progresses. And the research does bear out that that, of course, does not work to the best for either patients or for the treatment team themselves. So really at every meeting, bringing the treatment plan in and making sure, are we following through on this? Do we need to make adjustments? So what are the components of a successful team? We'll go through the structure as well as the individual members. So the core team includes the client and then the primary treating providers who work with the client. So that would be, the people that the client has the most contact with in the healthcare organization. And then the extended team can be quite large. This is really that whole constellation of who provides services for the client, as well as who are the loved ones or the concerned significant others who are involved in the client's care. I think an example that fits really well here is a dentist. We might not typically think of that as a provider who we'd bring in on the treatment planner to consult. But for those of you who have worked a lot with this population, you know that dental problems are very common, that a lot of patients are really, really concerned about finding a dentist who's going to be non-judgmental, who understands some of the particular concerns they may have about medications, et cetera. So that's an example of somebody who might not immediately come to mind, but is going to be really, really helpful to draw into the treatment planning and make sure that they're on the same page and are going to provide care that's consonant with the overall vision that the patient has agreed to. In terms of the structure of the team, really important to have a team lead that's responsible for the treatment plan as well as the team as a whole. So that's that sort of primary contact, and then similarly a coordinator or recovery coach who's responsible for organizing the team meetings and communication. We do all know that it can be hard to make those meetings happen and to keep all the documents organized. So it's really important to have a point person there. And then also having a flexible but also defined role for all the other team members. You know your scope and your role on the team, but also you're able to fulfill other roles as needed. We'll talk in this presentation about the importance of adequate staffing, and that is absolutely paramount for our own sake as well as for the patients. And also we know how important it is with this population to have sort of agile clinic structures. And sometimes it's just the case that, a coworker really needs that sick day, or there's a really high acuity case that they need to be drawn onto at the moment. And then having somebody else who can step into that role keeps things rolling forward smoothly. And that's very helpful for the patient's morale as well as for optimal functioning of the team. So in terms of the team leader program manager, this could be a doctor of medicine, a registered nurse, a physician's assistant, a nurse practitioner, or an independently licensed therapist. There's a lot of versatility here. The main thing is that you want to be the consistent point of contact for patients. And going back to the point I made earlier about, any of us who have had to navigate the healthcare system on our own or for our loved ones know it's really frustrating when you have to go through 3 or 4 or more people to get to who you need to speak to make things happen or to understand what's going on. And it's such a relief for patients who already are often ambivalent about engaging with treatment to just know who it is that they need to go to get the information they need. So this person coordinates the communication between the team members as well as between the team and the patient. And they also may have some patient care functions depending on how this is actualized at your organization. Often they're going to conduct supporter education groups for the program. And in the model that these slides are based on, which is the Massachusetts Collaborative Care Model, nurses were the ones that were studied. That's actually, nurses have been studied most frequently for these models across different approaches. And you really come to have an appreciation for the versatility of nurses in this role. And as long as they have adequate resources and staffing, how many patients they can care for with a very high standard of care in many different ways. In terms of the recovery coach or the engagement specialist, this could be a registered nurse, a community health worker, medical assistant, a peer support specialist. It does require training to step into this role. So even though there's a lot of different backgrounds, part of what you need to do is understand what goes into this particular role. Part of it is expanding services. So that includes filling in some of the administrative duties, in some cases as qualified, some clinical duties. I do want to highlight patient education because in the qualitative literature, this is something that makes a really big difference to people engaging in substance use disorder treatment. Just really getting psychoeducation that is accurate and reliable about, what is buprenorphine, how does it work, what's expected of me in this program, what do I need to do to stay in it and succeed, uh, information about harm reduction. Sometimes in these cases, it's important to pull in another team member if the patient has questions or if it's relevant to an area that's outside of your scope of competence. But it is important to make sure that this person is the sort of primary contact on these matters. And then as experience dictates, potentially facilitating or co-facilitating groups on important topics like overdose prevention or relapse prevention. And then also importantly, psychosocial support. This population really very often benefits disproportionately from psychosocial support. So that's all about getting those referrals done, checking in with the patients, phone and in-person check-ins. This is something that all of the prescribing providers on the hub team have really emphasized, and I appreciate that so much because on the behavioral health side, we really hear from patients that it makes a huge difference to know that their provider is there for them and is tracking them and, genuinely cares about how they're doing. All right, so possible referrals. So this could be made by anybody on the team. So a 12-step program, for example, Alcoholics Anonymous, Narcotics Anonymous, or SMART, SMART, SMART recovery. Traditional healers, depending on the background of the patient, inpatient treatment programs and RTCs, crisis line phone numbers. I do want to note that texting is now available, and that makes a huge difference for a lot of patients. Harm reduction sites, HIV and hepatitis testing and treatment services, particularly emergency food resources and housing and utility resources. Again, the qualitative literature has really highlighted that for this population, those kind of very concrete resources, especially if they can be supplied quickly, make a huge difference in building trust and helping patients to see that they are going to be reinforced and supported for engaging with treatment. And similarly, employment and education, as well as psychiatric and medical treatment. For the therapy, I do want to underscore that for opioid use disorder, medication is absolutely the centerpiece. That is over and over again shown by research to be the linchpin of progress. And then at the same time, opioid use disorder rarely occurs in a vacuum. There's very often co-occurring disorders, and then also alongside the progress that medication allows, most patients really, really benefit from learning new skills, how to restructure their lives in order to support their recovery, and being able to move into new health habits that reflect where they're going with their recovery. So that could include things like cognitive behavioral therapy, relapse prevention, motivational interviewing, contingency management, 12-step facilitation, and so on. And, ideally, it usually goes most smoothly if you have an in-house behavioral health team as available, but also those outside references are crucial. And that's one of those things that I think ECHO is great about. We all get to know each other in the community. And I think that helps a lot in terms of providing referrals to people that you actually know. The pharmacist, I feel like pharmacists are really kind of underestimated in terms of their role on the team. It's a face that the patient puts to the treatment. And pharmacists sometimes can be that front line of recognizing, concerning behaviors or, anything that needs to be relayed to the team to make sure that the patient is being adequately supported. So that would include, distributing naloxone, patient education, first responder community education, as well as physician education on chronic pain management practices for this population in particular, identifying high-risk patients, and then, of course, co-prescription of naloxone. For advanced practice nurses, physician's assistants, midwives, and doctors of medicine, also able to manage and administer naltrexone, do the physical examination, assess appropriateness for treatment, provide the prescriptions for buprenorphine, and then also, very importantly, historically, this has mainly been the role of physicians to provide training and education to the rest of the team. But with the collaborative care model, we're recognizing that expanding that role of education to other members of the team can be really critical. So this, I'm not going to go over the whole thing, but this is a slide that's in here for reference in terms of the office staff training for buprenorphine and who should be involved. And I do want to draw your attention to all of the boxes here that say all staff, because I think it really says a lot about how holistic we want the approach to be for substance use disorders. So thinking of things like a basic understanding of addiction, that is really important for everyone from obviously the prescribing providers to also the front desk staff and the people who are answering the phone and anybody who's going to be interacting with the patients. That's going to help them also with number 4, handling the challenging behaviors, setting appropriate boundaries, and also addressing staff concerns, right? So this is all part of creating that anti-stigma environment that's going to allow patients to engage effectively with treatment, feel comfortable, and feel motivated to come in. And then, of course, there are some more esoteric roles where with prior auths or prior notifications, those are people who need to be specifically trained for the billing. Uh, Behavior contract is one that goes along with the AL staff for the most part. You really want to make sure everyone understands what the organizational rules are and what accommodations, as relevant, need to be made for particular patients. And then nurses or MAs for follow-up visits, phone scripts for front office, and then PMP, it is important to have one agent for each site per prescriber because you do want to make sure nothing falls through the cracks there. So I mentioned the Massachusetts Collaborative Care Model earlier. This is, I think, the earliest, or at least the earliest prominent one of its type. And very much like what we're doing here with ECHO, they were interested in how do we increase local capacity. We all know that for substance use disorders, there's more patients that need care than we have qualified providers. So this is all about how do we make the most of what we have. And then also through programs like ECHO, make sure that we, expand that care network. So again, the linchpin there is the team-based approach, making the most of an interdisciplinary team. And back in the days of data wavering, this actually increased wavered physicians 375% in 3 years, which is pretty extraordinary. And very, very notably increased patients on medication for opioid use disorder, particularly minorities, which we know historically have been unfortunately left to the margins for medication. Again, the nurse care managers were really critical. They were central to this process. And what they found in these studies was that one nurse care manager plus one medical assistant could effectively cover 125 patients on average, which did make it financially viable and sustainable for the organizations. And that is really impressive. It really says a lot about what a well-coordinated team can do to make sure that just a couple of those people in the lead placement positions can do the best for their role. So this is one, again, that's a reference slide, but this shows that overall patient flow for the OBOT, that's office-based opioid treatment. So you have the initial screening assessment. The chart review is important to be a whole team effort, as we mentioned earlier. And then for the MD, there's the much more specific medically oriented tasks. One of the things I want to draw attention to here is that there are more people in the latter phases here with support and titration during induction, stabilization, monitoring, and maintenance with follow-up. And just pointing out that you do want to make sure the patient is feeling supported and kind of held in that web of care so that they know who they're working with, they're getting those follow-up calls, they really feel like, in a sense, they are part of the team, or as Dr. Bott says, the captain of the ship with their treatment plan. Again, a reference slide, but that initial screening assessment, you get a sense of how comprehensive ideally you want to be. And again, drawing attention to the importance of educating patients about buprenorphine. This is one thing that is just so consistent in the qualitative literature, that patients who feel that their providers were very patient and very clear in providing information about buprenorphine are much more likely to be retained in treatment and to engage effectively with treatment. And then the importance of training, and I feel like that's kind of meta-communicated through what we've already talked about, but to be more specific, the importance of buprenorphine waiver training, or in the current iteration, what we're doing now. The addictions and buprenorphine 101 training for all staff. So, we wouldn't expect all staff to understand everything about this, but we do want to make sure that there's a top-down understanding so that we can all communicate effectively, as well as be liaisons to the patients. And then again, going back to that chart, how to work with individuals with substance use disorders. We know that sometimes there can be particularly challenging or antagonistic presentations in this population. And the better prepared staff are in terms of understanding where that behavior comes from and how to manage it in a way that's best for both the staff and the patients. It makes everybody happier. It makes sure that patients stay in care, and it's the gold standard. Ongoing trainings and shadowing opportunities. This is again about increasing capacity. We want to draw everybody in that we can and make sure we're reducing the barriers to providing treatment. Telehealth and email backup. You all, hopefully, if you've been here a few times, have heard about the poison control hotline through Dr. Warwick. That's an example of one of the pieces where modern technology allows us to provide just really extraordinary top quality expertise right over the phone. And hopefully that is helping providers who might feel a little bit nervous about starting up with prescribing in this area, knowing that they have an expert at the drop of a hat on the phone. And then, of course, with policies and procedures, we want to be flexible enough to be able to adapt them to individual circumstances that are going to benefit the patient. Of course, billing support. And then in terms of office-based opioid treatment, you do want to make sure you're providing the rationale in terms of a lot of patients are going to be much more comfortable receiving treatment from a known provider, somebody that they've been seeing for a while. And I know we have a lot of those folks on Echo, which is always really wonderful to see. It's an important open door to treatment. And making sure that that those providers really have all of the training and the information that they need, as well as the access to backup and consultation in order to make sure that you know they're feeling confident to take the best care of patients that they can. So those are components of those OBOT core training programs. Now, I said that there would be a little piece for clinical administrators here, and that's, you know, just in case there are people here who currently are or who may be in the future working in administration. We do really want to emphasize that the literature really indicates that sometimes the administrative factors are a really significant barrier for the team in terms of doing the work that they need to do to support the treatment. And this is a place where there's just a lot of room to be able to support the success of the team. You want to allow for regular meetings, make sure that open communication is encouraged and supported, ensure that there's adequate staffing, you know, that we don't need to worry about coverage for patients. We talked before about with the Massachusetts collaborative care model about what an appropriate ratio is, and there is increasingly, you know, research to support what specific proportions work. And then allowing time for trainings and continuing education. You know, we know that, for instance, with the fentanyl era coming on board in the last few years, things have changed in this landscape. And even if you've been very well trained, there are new things that you need to do to take the best care of your patients and to communicate effectively on an interdisciplinary team. So making sure that the staff has time to engage in that. And then creating the clinic policies and the guidelines in conjunction with the team to make sure that you're getting that feedback that the whole clinic is going to be able to be on board with this and work at their best capacities. So what can we do to end on an empowering note? As always, you know, in every field, be an advocate for your patients and recognizing that with this population, these patients really require a lot of advocacy. They're working uphill against social stigma. For the same reason, helping to create an accepting and patient-centered environment. I know I'm a little biased coming from behavioral health, but I think this factor is really underestimated. I can't tell you how often I've heard from patients that it was about, you know, smiles at the front desk, you know, a friendly security guard, you know, whatever it was. It's these so-called social architecture, sort of soft features of the clinic that helped them stay in treatment when they were having a hard time. So I want to put a shout out for how important that is. Working within the community and beyond to combat stigma, you know, this is something that's going to help everybody even before they get into treatment to at least consider the option. And then working at every level, right, from grassroots and up on policy. So tribal, state, national leadership, how do we enact policies that are going to benefit communities? So those could include funding for treatments, substance take-back programs, education that's aimed specifically at community members, youth engagement, and of course, naloxone distribution programs.